opportunity. And this IC is based on all the clinical emergencies that we face in ophthalmology. There are certain situations when we really need to be on our toes. We do not have time to waste, and the plan of action, what we are going to do the next for the patient, that has to be clear right there from the very beginning. And this IC is going to do that for you. And I hope that at the end of this session, we all go back with few clinical tips that we can use in our routine practice. So with this idea in our mind, I'm going to invite Dr. Shweta Atishwar for her talk. And she's a wonderful speaker. She's a very good surgeon, and she's a RIO alumni, RIO Chennai. Thank you, Shweta, for being.
Thank you, Dr. Mamta, for including me in this instruction course. And I thank the AIOS Scientific Committee for the opportunity. So I'll be talking about managing acute congestive glaucoma today. So each of us here has about 10 minutes to talk about these ophthalmic emergencies. Hopefully, when such a patient walks into your OPD, you will be able to act within 10 minutes and manage them well. So acute angle closure glaucoma, as we all know, it's a potentially blinding ophthalmic emergency caused due to extreme increase in intraocular pressure due to a relatively sudden blockage of the trabecular meshwork. But before we dive into managing acute angle closure glaucoma, let's quickly recap the natural history and staging of angle closure glaucoma. So in primary angle closure suspect patients, there is iridotrabecular contact of more than 6 clock hours, but usually the intraocular pressure is normal. In primary angle closure, you have more than 180 degrees of iridotrabecular contact along with elevated intraocular pressure and peripheral anterior synechia. And when you have primary angle closure glaucoma, you have all of these features. Additionally, there is optic nerve damage as evidenced by perimetric changes and thinning of the retinal nerve fiber layers. We are going to be talking about acute angle closure crisis, which is a very sudden event, but there are some predisposing factors. So angle closure glaucoma, as we all know, is more common in Asian population, a little more common in females. Elderly patients with hypermetropia. Family history, if there is a family history in a first-degree relative, the patient is at increased risk. Then certain ocular biometric factors like shallow anterior chamber, short axial length, increased anterior curvature of the crystalline lens, a thick, bunched-up iris. These are some of the risk factors. Then certain topical and systemic medications which dilate the pupil or cause anterior rotation of the ciliary body in at-risk patients is something we need to keep in mind as well. And then stressful events or prolonged exposure to dim illumination is what can precipitate an attack of acute angle closure. So before we move on to how the patient presents, this is something important to remember. There are a lot of drugs that can cause acute angle closure, but the two very common and very important ones to remember are topiramate, which is an anti-epileptic drug used in the treatment of migraines, and escitalopram. It's a very commonly used antidepressant drug, goes by the tablet Nexito, and it's a selective serotonin reuptake inhibitor, and has been known to cause acute angle closure glaucoma. So just the common drugs should be kept in mind when you're seeing a patient with acute congestive glaucoma. Now, when this patient comes and sits in front of you in front of the slit lamp, the first thing you need to think about is what is causing this angle closure. So what is the mechanism of angle closure? Now, there are potentially 4 levels at which this can happen. One is at the level of the pupil, which is the most common, pupillary block glaucoma. Then the other thing could be at the level of the ciliary body, maybe due to a plateau iris, or if the peripheral iris is bunched up or iris crowding. So then it can happen at the level of the lens because of a phacomorphic glaucoma or a microspherophakia or a subluxated lens. And then at times the cause can be retrolenticular, as in malignant glaucoma or a supraciliary effusion or a massive vitreous hemorrhage too. So like I said, it's very important to quickly determine what is causing this angle closure in this particular patient sitting in front of you. And why that is important is because pupil block mechanisms respond well to treatment with pilocarpine, But the same pilocarpine can spell trouble when you use it in lenticular and retrolenticular causes. So for the posterior mechanisms, you have to use a cycloplegic agent like atropine or cyclopentolate. So this is something, I cannot overemphasize the importance of this point. So the patients typically present with blurred vision, rainbow halos around lights, pain, redness, headache, nausea, and vomiting. And the diagnosis of acute congestive glaucoma is largely clinical. Intraocular pressures are extremely high, usually more than 35 millimeters of mercury. There's circumcorneal congestion, corneal edema. There's a shallow or a flat anterior chamber. More often than not, we do see some anterior chamber reaction as well. Closed angles on gonioscopy. There's usually a mid-dilated, sluggish pupil. And you may end up seeing some signs of previous angle closure attack, maybe like peripheral anterior synechiae, some iris atrophy, glaucoma flecken, posterior synechiae, or irregular pupil. And if corneal edema is not too bad and visualization permits, you will be able to see a hyperemic optic disc in acute cases. Now, gonioscopy is diagnostic. You will see the extent of angle closure, presence of anterior synechiae on gonioscopy, but sometimes corneal edema may preclude proper visualization. So this is a quick, simple test on the slit lamp, the peripheral anterior chamber depth. You can grade the shallowness using the Van Herrick's grading, wherein you use a very narrow slit of the slit lamp, project it at the limbus at about 60 degrees, and compare the thickness of the cornea with the dark area that you see in the anterior chamber. So Scheimpflug imaging can also prove useful sometimes when corneal edema is very severe and you're not able to do any sort of grading on the slit lamp. And if you have access, there are certain diagnostic modalities like anterior segment OCT and ultrasound biomicroscopy. So whenever there's a doubt about the mechanism of glaucoma, you may use these to rule out secondary causes like maybe a plateau iris or uveal tumors or malignant glaucoma. So what are the principles of management? First and foremost, we make the patient comfortable, relieve headache and nausea. The next thing is to lower the intraocular pressure immediately, then to rule out secondary causes of angle closure, and to relieve the pupillary block. So what are the immediate steps? So first and foremost, give the patient some analgesic and antiemetic if there's nausea and vomiting. Start the patient immediately on acetazolamide, 500 milligram orally if there's no vomiting, or intravenous mannitol, 20%, 1 to 2 gram per kg over 1 hour. Or the other commonly used drugs are 50% glycerol or oral isosorbide. Now, we need to be very careful about contraindications to these drugs, which I'll talk about briefly. So once you've given some sort of systemic medication, these are hyperosmotic agents, then you also add topical aqueous suppressants. You can start the patient on timolol or brimonidine or dorzolamide eye drops. And more often than not, there is some anterior chamber reaction. So you are advised to start prednisolone or dexamethasone eye drops, QID. So a few things to keep in mind. If the patient is allergic to sulfonamides, has impaired renal function, then you are better off holding off acetazolamide. Acetazolamide also causes a few common side effects: paresthesias, polyuria, and fatigue. Mannitol is contraindicated in patients with renal disease, congestive heart failure, and pulmonary edema. Glycerol is contraindicated in diabetics. And topical beta blockers are better avoided in patients with asthma, and alpha agonists are avoided in patients with coronary artery disease. So once you have taken these measures to lower the intraocular pressure, maybe you can reassess the patient after 30 to 60 minutes, and then start the patient on pilocarpine eye drops. This is a miotic eye drop, and sometimes when we all know that when the intraocular pressure is very high, and if there is sphincter ischemia, pilocarpine doesn't act very well. So which is why lowering intraocular pressure is the more priority step, right? So once you've started the patient on pilocarpine, you can instill the drops every 15 minutes, thrice. and keep up with the timolol or brimonidine eye drops, with the topical steroids. And then you can step down the oral acetazolamide, make it probably 250 milligrams TDS or QID. The most definitive way to relieve the pupillary block is a laser peripheral iridotomy. Now, sometimes the corneal edema can preclude your visualization. In that case, you can use topical hypertonic saline and 50% glycerol to sort of decongest the cornea. And then you have to get ahead and go ahead with a Nd:YAG laser peripheral iridotomy. So typically 5 millijoules, 4 to 8 shots, choose a superior location, and make sure that the size is at least 200 microns. Now, laser peripheral iridotomies can get occluded within the first few days after the iridotomy because of pigment block or tissue debris. So which is why you should ensure that the minimum size is at least 200 microns. All right. If that doesn't give you an adequate IOP control, you can go ahead and do a laser peripheral iridoplasty using argon laser. Now, what this iridoplasty does is it sort of retracts the iris tissue and opens up the angle. This doesn't seem to provide long-term IOP control, but as a short-term measure, if LPI fails, you can go ahead and do a peripheral iridoplasty. If this doesn't work, you have no choice but to go in for a surgical iridectomy. And what is must is doing a prophylactic laser peripheral iridotomy in the fellow eye. So here is a quick reference flow chart for the management of acute angle closure glaucoma. So it's a stepwise approach. We start off with analgesia and antiemetics. Then we examine to measure the IOP and identify or exclude secondary causes. Then we identify allergies and contraindications because we are going to use drugs to lower the intraocular pressure. So we need to know the renal status of the patient, whether there's any congestive heart failure, any coronary artery disease. And while you're at it, also quickly ask for drug history of, say, topiramate or escitalopram. The next step is to start either your intravenous mannitol or acetazolamide, topical aqueous suppressants, and pilocarpine eye drops. Review maybe about after an hour, and then definite laser peripheral iridotomy in both eyes. After the iridotomy, add steroid eye drops hourly for the day, and then 4 times a day for 1 week. After a couple of hours, please reassess the response, and then if it is IOP control is not adequate, consider a peripheral laser iridoplasty. Once you settle the patient, if there are any secondary causes, we need to treat the primary pathology. And one important thing to remember is lenticular and retrolenticular causes have to be treated with atropine and not pilocarpine. And I'll just sum up. Follow-up is extremely important. Sometimes in emergencies, we manage the acute condition, and then, we have to tell the patient follow-up is extremely important. So I would generally follow up on day 1, day 3, day 7. And then, investigate. We have to look for the LPI patency and repeat the iridotomy if it doesn't open up after the first 1 week. And then, of course, assess the perimetry and do an RNFL thickness analysis. And based on the pressure control, adjust medications if required. Thank you.
Thank you so much, Sweta. We'll take up questions at the end of the session. So the next speaker we have today is Dr. Deepak Mishra, and thankfully I do not need to introduce him. He has been doing it for the last 3-4 months, courtesy AIO selection. So Dr. Deepak Mishra is going to talk about the penetrating ocular trauma. Thank you, Dr.
Thank you, Dr. Mamta, for including me in your IC. There is no financial interest in this talk. Everywhere there are different classification, but for the international classification guidelines, we have either it's open globe or the closed globe injury. And the topic Dr. Mamta allotted to me is the penetrating injury. So there is only one confusion, means when we say it is a penetrating or when it is a perforating. When there is one entry wound, means there is something which goes inside but not there is an outside track, then it is known as penetrating. And when there is both, means either both wounds are present, entry and exit, then it is a perforating. So another one is why it is important to know or manage the penetrating injury. So when we go for the epidemiology or the data, then we find out that it is the almost the most common unilateral cause of loss of vision, and that is not the important thing that it is the cause of vision. Important is that 90% of them can be prevented, means it is a preventable cause of disease, vision, and if we have some knowledge or good knowledge, we can prevent it. So whatever the vision loss is there by this penetrating injury, so we can reduce the burden too. And most important is that 50% of them are less than the 25 years of age, and 34% are of the pediatric age group. Again, I am saying these type of penetrating injuries are more common in the pediatric age group. We all often see that someone hit by pencil, some another thing, or different kinds of injuries are there in the pediatric age group, and they required GA. That is another problem for those for management of their injury or their perforation, because we have to depend upon the anesthetics and at least 6 hours empty stomach, different status are there, GA requirements is there. But knowing the data and the prevalence, we can have some better vision there. What happens, these type of penetrating injuries have different kind of effects. One is the mechanical, what I have just tell you all, that there may be the laceration, or sometimes there is tear may be in the cornea, corneoscleral, sometimes up to the retina if there is high moving sharp objects are there, sometimes vitreous hemorrhage and different things. So these are the mechanical effects that is caused by the agent which from which we got the injury. But another one which is not less damaging is the introduction of infections along with these track, because you know the whole eyeball is protective for us. When you have damage somewhere or anywhere, then there is chances of growth of the infections inside, and if not in this side, not properly managed one eye, then another eye, that is another sympathetic ophthalmitis, means we these penetrating injuries directly damage something, then there may be chances of infection with them, and if all them not at present, then later on there is chance of sympathetic ophthalmitis, means all sorts of vision loss or the possibility are there with these penetrating injuries. Now most important what I can say is the evaluation is very much important, because we have to rule out what is the cause, not only the ocular cause but the non-ocular causes of injuries can also be kept in mind. Another thing is time and place. What happens most of the time in adolescent or even the child, these injuries are may lead to the medical legal issues or something. You can say FIR is there or police case is there, someone hit to someone. So date, place and timing of injury is very much important, not only for the management but also to save us from the medical legal issues later on or for the child too. Another is this check the vital signs, because if these are the pediatric age group or another age group, so you have to um, take consent of the anesthetics to do, so they will do each and everything. Also not only examine the corneal part but also examine the external injury. Most of the time we forgot to find out something which happens. I am tell you one example in which there is small corneal perforation in my OPD, and we said it's easily repaired by one suture, something like that. But the boy has hit on the back of the scalp too, and that is the reason for the loss of the vision. And we are unable to searching or doing taking history why there is no vision, no vision. He or she is happy. There is a pituitary damage in that eye boy, and gradually we are searching why, because of such a small perforation there is loss of vision. So these external examinations will tell you how important is the examination of whole face or the scalp or the brain injury too, along with these injuries. Another one is whenever you have to record the visual acuity of both eye. That is the most commonly uh, mistaken point in the all the medical legal cases, that when you are examining or doing something, you miss the examination of another eye. Sometimes we have a habit of writing ODOS or up and right arrow, but we ophthalmologists know means up is right and down is left. in the court case or any of the other medical legal cases, we forgot. Or sometimes we, if not writing clearly right eye, left eye or ODOS, then we again himself forget that vision is of which eye. Though that is the important for each and everyone. Now coming to the individual evaluation before going to management in a brief, whatever the things is possible, do by the torchlight assisted with the slit lamp examination. And slit lamp examination in the cornea, what we can say, we have to look out each and every point, means even in the conjunctiva, foreign body, where hemorrhage is there, laceration is there, cornea defect, and whenever we find out any corneal perforation, then try to elaborate or make a diagram or whatever is the possible handmade diagram, what is the length, depth or width of the injury. Scleral, again laceration and rupture both. Anterior chamber, apart from the normal things, look for the foreign body if you are expecting something like that. And same the iris and angle, what is the type of wound, whether iris is attached or not, any iododialysis is there or not. So these are the common points I summarized for we have to in mind when looking for the injuries. Same for the lenses, whatever the position of lens, whether dislocation, breach in continuity or axis or anything, you have to go for that. Apart from these evaluations, sometimes it's not possible because of the chemosis. Chemosis is the factor, or we sometimes unable to open the lid. In that too, examination is very much important. Whenever is required, either X-ray, USG or CT scan, go for it. Don't be afraid of doing any such investigation, but I'm telling you, these will guide us better and save us in the management too. If it is required or something injury is having more than 24 hours or 72 hours and you suspecting some infection component is there, then also go for the culture of the whatever the tissue you removed, either incarcerated iris or the cornea or the tear film. Again go for the culture and sensitivity, so that after proper repairing you go for the good antibiotic coverage for him too. Now I'm coming to the exact management, which is apart from the beginning or the symptomatic management for the child or the anyone having perforating injury is analgesic, antibiotic, patching, atropine, whatever we are doing is the same, but the principally we have to correct the by the repair of these perforations. So primary repair is of the corneal repair is aim is to have a watertight closure of the globe, whatever is the possible, and second is the restoration of secondary structures. Apart from that, there are many secondary objectives we can say, but two I am saying you everyone should know that avoidance of any uveal tissue incarceration in wound. That is the most important point when you are repairing this with iris damage. And if any foreign body is there, then at least remove. Try to removal of foreign body is as important as removal of incarcerated iris tissue. So this is just I am trying to make a graph where sutures should be placed so that it will be ideal. What you have seen here, if my pointer is there, whatever the depth of the suture, these sutures act as a vector manner. Whatever the height is there, similarly they will go at a 45-degree angle, make here and to here. So the placement of suture and this length both is important, not only the width but the length of suture is important in the corneal tissue. Just I am saying that because most of the time the edges have the edema, so if you sutured with the edematous part or anything, then next day there may be a chance that either it will be a loose suture or it will be slipped off. So this diagram will help you to understand how suturing should be performed in the different segment. Although it's a very big topic, I'm not going in detail, but just trying to say something that, give me 1 minute more. Here, whatever is the horizontal and the vertical direction, just place the sutures half of the distance of the vertical. Now coming to the corneoscleral suture with iris incarceration, most important is whenever is in the iris tissue is there, first of all you have to irrigate and clean it whatever is the possible as possible by the fluid or the solution, and start if there is a limbus tear, then mostly give a stay suture at limbus, because limbus is the toughest structure. So when you have stay there, you have a good chance that you approximate well both cornea and the sclera. However, the lens is incarcerated or anything, then you have to remove the IOL, whatever is the, if lens matter is there, either by ECC or by same wound or SICS, whatever you can prefer. If we have some IOL implantation or something at the same sitting, usually it is difficult and people avoid IOL implantation at same sitting, but it is small wound, not infected, and you think whole lens material is lost or something sloughed out because of that, then you can go even for the IOL implantation with or without vitrectomy. Now coming to the sclera repair, it is again important as the cornea. What is important is we have to where is the main problem? Main problem is in the sclera. You didn't know just the back extension of the sclera. So we have to start with the anterior point of the sclera where we find out the tear and go slowly to posterior. Whatever the possible, go for the long waist. So identify first the plane of the dissection, means it will be episcleral tissue and scleral are separated. You closely separate it till you find out the another edge where the sclera is automatically attached or non-perforated or non-same. So identify the edge and start suturing from anterior and go slowly to the posterior. But always try to go as close as possible. Sometimes it is not possible to go close because there's not only the penetration is there, there is rupture of a globe is also there, so it will be more posterior segment. So there we can have to go more posteriorly, but try to find out that there is no distortion or torsion on the globe because of your so much posterior suturing. And sometimes there the perforation or penetration is such a way that it also involves the extraocular muscles. So don't afraid of it. Whatever the repair you have done, you've done, and after that again suture your muscle too, whatever is the possible, so that we sometimes just repair the sclera and forget about the muscle, or sometimes it is not possible to identify that muscle is also broken, some tendon is involved. But we have to look, since we all are knowing the anatomical position of the muscles, so we are knowing that yes, if muscle is involved or not. Even you can check on the OT table too by pulling the muscle like you are doing in a squint surgery, how to repair it. This is the timing I am saying most important factor apart from the surgery, which is not in our hand. It's because sometimes patients come late or delayed, but the timing is as we can do. If it is repaired within 24 hours, it is the best to repair within 24 hours. If not possible, then whatever is the earliest we can do for that. So my take home message is first the proper planning and counseling of the patient, that what is the problem, how is the outcome of the vision, that is important, your presenting vision, and all sort of complications what you are expecting from sympathetic ophthalmitis to easier one like small eye or foreign body sensation or anything, explain to the patient. Timing, again I am saying timing is the important thing, so do it as early as possible. And documentation, I tell you, this is the only thing which save you in each and every point. Sometimes after the good perforation repair or anything, patient said he lost vision because of the surgery. They are not ready to accept that the vision loss is because of the injury or anything. They want that if operation is done, then vision should be 6/6, which is not possible. So at least document the pre-surgical vision if possible, or the post-surgical vision, and also take a proper consent for all medical legal cases, because nowadays perforation is common in the court cases too. With this, I would like to thanks again Dr. Mamta for giving me this opportunity.
Thank you, Dr.
Thank you.
Thank you so much for that. Next, we have Dr. Sharmila Devi, a faculty from RIO, and she is the Joint Secretary of Tamil Nadu Ophthalmic Association, the past editor also of the official journal of Tamil Nadu. And she will be talking about the blunt trauma to eye.
Good morning, everyone. At the outset, I would committee and the Chief Instructor, Dr. Mamta, for making me part of this session. My topic is management of ocular blunt trauma. And I think some of the points were highlighted by Dr. Deepak Mishra. Ocular trauma is a leading cause of monocular blindness, and it's very important because it's preventable. And it's more common in males and the pediatric pediatric age group, and 50% under 40 years of age. It's preventable blindness, and that's why it's been given more importance. History taking is very important, history and documentation. Why? Because we might be attending the ocular trauma, and there might be a concomitant life-threatening injury which might be missed. So it's very important to know about the nature of trauma, the nature of the inciting object, and the past ocular history is also very important, whether the patient had any refractory error and any other ocular complication. And the type of composition of intraocular foreign body, that is also very important. I think this classification was touched upon by Dr. Deepak Mishra. So what are we looking at? The questions that we should ask, and the findings that we should look for is there an eye wall defect? If so, it is an open globe injury. If there is no eye wall defect, then it's a closed globe trauma. In a closed globe trauma, again, is there a partial thickness defect? Then it becomes a yes. Then it becomes, if there is no partial thickness defect, then it becomes a contusion. And if there is a defect, it becomes a lamellar laceration. And was the injuring object blunt or sharp? If it is blunt, it is called a globe rupture. And if it is sharp, it is called a laceration. And laceration, you have the penetrating injury and the perforating injury, which was explained in detail by Dr. Deepak. And this is the comprehensive classification. It is given in Birmingham Eye Trauma Terminology System, or the BET system. And this is what we should use for classifying ocular trauma. And prognostication should be done by ocular trauma scoring. And this is very important because this was proposed based on the Birmingham Eye Trauma Registry and the Hungarian Trauma Registry. And this ocular trauma score can be used to give the prognosis to the patient, whether after repair, whether the patient will have a good prognosis or a bad prognosis. So most commonly what we see is a periocular hematoma, and it's important to exclude the fractures. It can trauma to the globe orbit, all types of fractures, roof, basal skull, and blowout. And sometimes patients can present with a proptosis with retrobulbar hemorrhage and with increased intraocular pressure. And then you might have to do a cantholysis to prevent damage to the optic nerve. So I'll not be touching much on orbit. I'll restrict myself to anterior segment. So what are the suspicious signs following trauma? You can have circumcorneal congestion. And in closed globe trauma, you can have injury to the iris or the ciliary body vessels, and you can have hyphema. And the rest were touched upon by Dr. Deepak. You can have iridodialysis and all kinds of lens-induced complications. You can have a subluxated lens. You can have a dislocated lens. You can have an anterior lens capsule breach and an early cataract. You can have an incomplete or a complete osseous ring. And most of the time, the patients present to you later after a closed globe trauma. The telltale sign can be a sphincter tear. So please look for the sphincter tear, and these patients can present to you with a late post-traumatic glaucoma, iridodialysis. So on examination, when you see a hemorrhagic emesis, you should think about an occult scleral tear. Sometimes you can have DM folds. So the DM folds can be due to contusion, or it can be due to hypotony. So it's very important to know whether the DM folds are because of hypotony or just because of contusion. And then the rest of it you should be documenting as per the guidelines. And what is the most commonest anterior segment complication which you can have following a closed globe trauma? It's high intraocular pressure. So the early onset can be due to trabeculitis or traumatic hyphema. And when do you call it a post-traumatic glaucoma? When the baseline intraocular pressure. What we are looking at is the baseline intraocular pressure. It should be over 21 millimeters of mercury. And if you're treating the patient for 3 months, then you call it a post-traumatic glaucoma. The late onset causes can be angle recession, ghost cell glaucoma, lens-induced glaucoma. Peripheral anterior synechiae can cause closure of cyclodialysis cleft and suprachoroidal hemorrhage. I'll be touching upon this later. So you're looking at different types of hyphema. It's very important to grade the hyphema, especially for postgraduates, and document it properly. Why is it important? Because the treatment guidelines are based on that. So the first two pictures, the microhyphema and the grade 1, you can just observe and put them on a conservative management. Grade 2 and grade 3, you probably need to record the intraocular pressure and take a call based on the intraocular pressure. The intraocular pressure recording in a closed globe trauma is done using a rebound tonometry, that is an IK tonometer. Grade 3 and grade 4, it's better to take them for paracentesis. And you should always remember the 8-ball hyphema, which is like a favorite question for examiners. So what are the indications for surgery? If their intraocular pressure is 60 millimeters of mercury for 2 days, 50 millimeters of mercury for 5 days, or 35 millimeters of mercury for 7 days, then definitely you have to take the patient for a paracentesis and remove the blood clot. And for sickle cell disease, you need to have a very low threshold, because in sickle cell disease, even if there is an intraocular pressure of 25 millimeter of mercury for more than 24 hours, it can damage the optic nerve. So you have to have a low threshold for sickle cell disease and take the patient earlier for surgical management if the intraocular pressure is about 25 millimeters of mercury. Why should you intervene? Otherwise, what will happen? Not only damage to the optic nerve, but you can also have a corneal blood staining. Late post-traumatic glaucoma, Gosal glaucoma can be a cause. So what happens here? You have a vitreous hemorrhage, you have the RBCs in the vitreous cavity which undergo morphological, rheological changes. So the biconvex red RBCs become spherical, hollow or khaki colored, and they become less pliable. And microscopically, you can also see the Haynes bodies. So these are Gauss cells, and that is the Candy stripe sign, which again is a examiner's question. So what you have in the Candy stripe sign is you have a streak of fresh blood layered over khaki colored hyperpion, and that's a very pathognomonic sign for Gosal glaucoma. So Gosal glaucoma happens only when there is a tear in the anterior hyaloid face. So how do you manage this? I think Dr. Shweta touched upon it. Topical and systemic anti-glaucoma medications. You avoid pilocarpine here because it can cause inflammation, and PG analogs are not indicated. So you start off with beta blockers, brimonidine, and topical carbonic anhydrase inhibitors. It's important to avoid carbonic anhydrase inhibitors in sickle cell disease, as it can cause acidosis and it can increase the sickling. And AC lavage, we've already spoken about it. For Gosal glaucoma, it's essential to do a vitrectomy also. And most of these cases are intractable glaucomas, and they definitely need a trab with a pharmacological modulation, especially with the mitomycin C or ologen. And sometimes you might have to do a tube also for them. So that is a case of hemophilia. This patient had a very trivial trauma and he had undergone a paracentesis also. But you can see the blood staining of cornea because the intraocular pressure was not properly monitored and managed. So it's very essential to properly document the intraocular pressure and manage it accordingly. So this patient underwent a triple procedure, penetrating keratoplasty with intraocular lens. You can also do a DSEC with cataractous lens if needed, removal if needed. Angle recession glaucoma is again an important cause of post-traumatic glaucoma. Now, what is angle recession? It is just a disruption of the longitudinal from the circular fibers of the ciliary body. Now, that's a misnomer. That is not going to cause glaucoma. It's only the trabecular scarring of fibrosis which is going to cause the glaucoma. So, what do you see? On gonioscopy, you see a broadened ciliary body band. And then whenever you have an angle recession glaucoma, you should make sure the patient comes to you for follow-up regularly because it can present with a late onset glaucoma. You definitely need to do an ultrasound biomicroscopy. I think the rest of the investigations were covered. You have to do a CT orbit, X-ray orbit to rule out presence of any foreign body and bony fractures. Sometimes you have to do an USG for assessment of posterior segment, and ultrasound biomicroscopy is very important in post-traumatic glaucomas. You have this angle recession. That's the second picture is a cyclodialysis cleft where you have a separation from the scleral spur. Why is cyclodialysis important? Because this paper gives you the predictors for the development of traumatic glaucomas. This paper is from RP Center by Dr. Amanjit Shihota et al. So what are the parameters? They say that these patients are prone for post-traumatic glaucomas. One is increased pigmentation of the angle. Another one is elevated baseline intraocular pressure, hyphema, lens displacement, angle recession of more than 180 degree. These are all positive predictors for the development of traumatic glaucomas. On UBM, if you have a wider angle and the absence of cyclodialysis, they are not very significant. That is what the paper concluded. So what you see here is a shallow anterior chamber with the cyclodialysis cleft on gonioscopy, and the patient has a hypotony maculopathy. So any patient with a low intraocular pressure, please check the posterior segment for hypotony maculopathy and do gonioscopy and a UBM. So why is this important? Because later stages, the cyclodialysis cleft can close and then the pressure can rise. But then, according to the paper, it's not a very important predictor for the development of post-traumatic glaucoma. Now, I'll show you some mimics. This is also closed globe trauma. But then if you look at it very closely, you can see all the DM folds. But if you look at it very closely, you can see this white spot. Okay, so if you get the history from this patient, this was a 12th standard boy who was just riding a two-wheeler, and then something fell on his eye and he just rubbed it. So it's just a trivial trauma, but then actually what happened is it's an insect stinger, and then I just have 30 seconds more. So it's just an insect stinger, and that insect stinger has caused a kind of an allergic reaction. So that insect stinger was removed and the patient was put on anti-allergics, and intracameral antibiotics also was given, and the anterior chamber was formed, and the patient is doing very well. And pediatric cases, you definitely, even in closed globe trauma, you have to put the patient under examination and anesthesia, or at least sedation, and look for, do a double eversion, because this patient was a firecracker injury. She was not doing very well even with adequate treatment. And then when we did an EUA, we found a incense stick which was used to light the firecracker that was behind the lid. So it's very important to do a proper evaluation case of pediatric cases, because they'll be crying incessantly and you won't feel like examining them, and you might miss a lot of these points. So eversion and examination and anesthesia is very important for pediatric cases. And this paper in IGO was for ban on firecracker injuries, because firecracker injuries can present to you with a lot of post-traumatic glaucomas, closed globe trauma and later post-traumatic glaucomas. Secondary prayer of intraocular trauma, I think it was touched upon by Dr. Deepak. So cataract extraction, definitely at some point you have to do it. So you have to plan it whether you want to do it early or later, and what type of, you have to assess the posterior segment and UBM properly before doing it. Posterior segment evaluation also has to be done, because these eyes are prone for commercial retinae, choroidal tears, and RDs, and intraocular pressure also has to be done frequently. Thank you. Thank you.
For the next topic, we have Dr. Vibhuti P. Sinha, who is going to talk about management of endophthalmitis. And he truly is the master of crisis management. He's the director and professor at RIO Patna. Thank you, sir.
The ICS chief instructor, so congratulations for that. I'll be talking on one of the topic which is very common, yet requires very aggressive kind of management, not in term of identification, but also in term of interventions also. So no financial interest. You know that there is inflammation in all the layers, and there is exudation of the material, inflammatory material inside the vitreous cavity as well as an anterior chamber. So this endophthalmitis is basically of two types. One is exogenous, which is more common. Endogenous is less common, 2 to 8%, but endogenous is devastating in terms of outcome. In the exogenous, you know, the post-surgical is one of the most common group, and which gives you a lot of headache because you are also involved with the surgical part of that patient. So these are some of the risk factors: systemic and local and intraoperative. Systemic diabetes mellitus, steroid therapy, septic foci, indwelling catheters. In the local, there are chances of inflammation or the bacterial colony occurrence into the lid sac. Also into the intraoperative phase, when the surgery is little prolonged or there is some amount of complication, or when you have not closed it properly, it can result into endophthalmitis. These are some of the etiological agent, but what we need to remember is in the acute phase, the staph is very common in the gram-negative, and it is very fulminant. Usually it is gram-negative. Pseudomonas or H. influenzae can be there in delayed. Propionibacterium acne is one common organism. In traumatic, Bacillus is very common, and one of the common organism is Streptococcus in cases of traumatic. And in endogenous also, the fungi and Bacillus is very common. So what happens? There is a microbial entry into the wound. There is a cascade of inflammatory product, inflammatory cell recruitment, release of the digestive enzymes, and release of these enzymes result into non-suppurative inflammation and suppurative inflammation, and that results into tissue necrosis and destruction, and that is very important. So coming to the exogenous, the post-cataract surgery is very common. PKP, glaucoma filtration surgery, pars plana vitrectomy, and now a newer group of exogenous endophthalmitis in term of intravitreal injections group is coming up. to the cataract surgery 0.04 to 0.15%, but these are the most challenging cases. In past penavitrectomy, the chances of occurrence is very less. In PKP, it can occur. In glaucoma filtering surgery, it is really devastating. As you can see, the chances of occurrence of this post cataract surgery end-op has increased over from 1990 to 2004 and 5 because of the advent of the clear corneal surgery, clear corneal wounds. In PKP, it is the incidence is 0.2 to 0.6%, and usually the organism is Staphylococcus and Streptococcus. In glaucoma filtering surgery, it is devastating, and Streptococcus is very common, and it gives you white on red appearance. And usually these are the patient, very challenging kind of patient where treatment always leads to failure of bleb. So there are double fold challenges in treating these patients. Coming to the post-operative endophthalmitis, if it occurs within 6 weeks, it is acute, fulminant when it occurs very early. In AVS, 94.2% were because of gram-positive bacteria. In delayed, it is usually because of the Propneobacter acne. In bleb, it is because of H. influenzae or some other organisms which can even penetrate through the intact epithelium. And blebitis can be the early feature and these are the patients who have been utilized with, who have been given antifibrotic agent during the surgery, and they have a very thin kind of bleb. These are the patients who are at risk of this endophthalmitis. In endogenous endophthalmitis, a bilaterality is very common. Indolent course is there, and systemic illness is of great concern. We must find out what is the systemic illness. The fungal candida and the aspergillosis are very common. In gram-negative, that is Klebsiella, and Staph and Streptococcus is also common. So what are the risk factors in endogenous? Immune suppression, prolonged indwelling catheter, IV drug uses, recent major abdominal surgery, diabetes, chronic alcoholisms, and we must find out the foci of the infection. We have to work twofold. One, to find out the septic of the foci, and second, we have to do this treatment part of the endophthalmitis itself. So coming to the clinical feature, the most common feature, that is blurred vision, redness, pain as per the occurrence, the chances of occurrence, then the photophobia and purulent discharge. Coming to the signs, it is from anterior to posterior. The eye is extremely angry, from conjunctiva, from lid to anterior chamber where you can find hypopyon. The posterior segment might not be visible, and you'll have to do further investigations. If posterior segment is visible, then you must grade the visibility, what you have seen, to what order the blood vessels are visible. That is going to give you a guide in the follow-up period. So in coming to the investigation, if the posterior segment is not visible, must do ultrasound biomicroscopy to find out the vitreous opacities or chorioretinal thickening, or look for the RD, CD, or retained intraocular foreign body, or retained lens matter in cases of the post-cataract surgery or in cases of trauma. Laboratory test, battery of tests need to be done in cases, more so in cases of endogenous endophthalmitis, because we are fighting with the septic foci also. So we need to find out where actually the septic foci is located. Coming to the eye, we have to do suture, we have to do such certain amount of that bacteriological evaluation, and from where we are going to get the material, that is the suture, IUL of bags. Aqueous tap is going to give you 40% positivity rate, and the vitreous tap is going to give 60% of the positivity rate. But we must be aware, and we must be doing all these procedures to find out the organism itself. Direct microscopy and culture has to be done, but now with the advent and with the availability of the PCR and NGS, you don't have to wait basically for giving intravitreal injections before you take out the sample. Even if the patient has been given intravitreal injection, you can still generate and identify the organism which is basically the culprit of this endophthalmitis. These are some of the differential diagnosis. In the early phase, you must identify the differentiating feature between the toxic TAS and the endophthalmitis. And in the TAS, you must remember that it occurs very early, eyes apparently silent. There is limbal to limbal edema with high IOP. There is fibrin, hypopyon, and hypopyon is sandy-like. It moves like. And if you dilate the pupil, if you give the cycloplegic and a steroid, the pupil dilates very nicely, and you can pip inside in the posterior segment to find out that there are no vitreous strands or the vitreous debris inside, and that will go in favor of toxic anterior and TAS. And there the mainstay of treatment is steroids, cycloplegics, and anti-glaucoma medications. And usually the patient responds well within 7 days, and the patient reverts back unless if there is very high grade of inflammations. So in endophthalmitis, the talk can't be complete without taking the name of endophthalmitis vitrectomy study, and that was the study which gave us role of the differentiating point between the role of intravitreal injection and early pars plana vitrectomy. When we say early pars plana vitrectomy, at that point of time, it was around 50% of the vitrectomy. So it was not a complete vitrectomy, rather partial vitrectomy. And role of IV antibiotics was important. And what was the result in the EVS? The result was, if the vision was hand movement or counting figure or better, there was no difference between the pars plana vitrectomy and intravitreal injections. And if it was PL positive or less, then naturally we have to move on for pars plana vitrectomy. But now with the advent of newer machines, newer drugs, the things have changed. In 2013 ESCR's guideline, what it suggests? It suggests immediate and complete pars plana vitrectomy in conjunction with the intravitreal injection is the gold standard, and immediate tap and inject is described as the silver standard. So what we can do is, if we don't have the facilities of pars plana vitrectomy, we can always give the patient with a broad spectrum antibiotic in the form of intravitreal injections, and then keep patient under observation, and if necessary, we can move for pars plana vitrectomy. However, in high-risk cases like a patient of diabetes mellitus or a patient where the inflammation grade is very high, or where the patient is immunocompromised or fungal infection we are suspecting, we have to move for a very early pars plana vitrectomy. So the treatment protocol is for control, eradicate infection, then manage complication and restoration of the vision. These are some of the antibiotics, corticosteroid and supportive therapy and vitrectomy are the mainstay of the treatment protocol. We must remember vancomycin and ceftazidime is still the mainstay of therapy in form of the intravitreal injections. But in case of the fungal endophthalmitis, we can move on to amphotericin B or voriconazole. Just 30 seconds. This chart one must remember. This chart one must keep in the operation theater. Dose alteration has to be done in the vitrectomized eye, silicone-filled eye, or the pediatric age group. Other factors, oral moxifloxacin has got some amount of effect, and steroid can also be given if there is a chances of inflammation is very high. So vitrectomy requires for increase the volume of the samples, the decreased microbial load, clears the media opacity with the rapid restoration of vision, and increases the efficacy of the intravitreal injections. This is the chart one must remember to go through a stepwise pattern to treat these patients, and some of the complications like panophthalmitis, glaucoma, orbital cellulitis, intracranial spread, septicemia. But what one must remember that if timely intervention is done in these post-operative cases, the result can be very heartening also. So take-home message, the devastation caused by infectious endophthalmitis can be vision and eye threatening. A patient with a history of diabetes, trauma, surgery are at high risk. One must take precaution during the surgical preoperative phase as well as before the surgery. Microbiology of vitreous is mandatory in all cases because virulence of infectious agent dictates the course and outcome of the disease. And endogenous and the traumatic endophthalmitis have generally a poor visual outcome. Thank you very much from core of my heart. Thank you, Dr. Mamta, for giving this.
Thank you, sir. As you said, early identification and the early intervention, that is the key of managing these cases. Thank you so much.
At the outset, I would like to thank AIOC Scientific Committee for giving me this opportunity, and Dr. Mamta, our Chief Instructor, for including me in this talk of ocular emergencies. My topic is central retinal artery occlusion, what next. Before going to the actual business, you must know what are the types of the central retinal artery occlusion. That is a central artery occlusion, of course, is a major chunk, 60% of cases. Branch retinal artery occlusion in 35% of cases. You have ciliary retinal artery occlusion in 5% of cases, and there may be combination of both retinal artery and vein occlusion, and also cotton spots, which again a form of artery occlusion or arterial occlusion. So, and another entity is paracentral acute middle maculopathy, that is needs to be discussed later on. So far as the causes is concerned, so we have to have a cholesterol crystal emboli. That is what we call is Hellenhorst spot. It is a main culprit, and it occurs in 74% of cases. And it is a once you see the fundus, you can see the refractile minute bright and golden to yellow orange to retinal bifurcation of the retinal fascia. And another emboli is calcium emboli, is 15.5% of cases, white single non-scintillating, arising from the cardiac process. So, and third culprit is a platelet fibrin emboli. So these are the cases. Once you present your central retinal occlusion, these are the real emergency apart from the ocular emergency, because these are the patients those are harboring the many other diseases like systemic illness and neurological illness, because the mechanism of there may be chances of having the plaque embolus in the cardiac and neurological phenomena disease also. So other causes may be there, like I am going to enumerate some atherosclerosis-related thrombosis, retinal arteritis, viability, including giant retinal cell arteritis, periarteritis, sachet pain, SLE, vagus, systemic diseases like diabetic hypertension. Again, you know, these are the culprit for that kind of things. Hyperviscosis syndrome and thromboembolic disorders. Traumatic fat emboli may cause central retinal artery occlusion and angiospasm causing hemorrhages. There may be a history of CVA also in those patients. Raised intraocular pressure, particularly after the RD surgery, and drug abuse and smoking. All these may lead to central retinal artery occlusion. So it occurs in, this is first described by von Grafe in 1859. It is really an ocular emergency condition. It is a condition where flow of blood through the central retinal artery is blocked or concluded. And cardiac emboli is more common in less than 40 years of age. So you have to have a patient with early age of CRO must have go for the cardiac evaluation in those cases. So far as epidemiology is concerned, 8.5% cases per lakh population, and mainly seen in older adults, early 60 years, and 90% presenting at the over 40 years of age. It is more common in male, and usually it is not bilateral, but it can be in 1 to 2% of cases. So far as the classification is concerned, it is you can divide into FFA based and pathophysiologically based, which was in vogue, non-arteritic CRO and arteritic CRO. FFA based is non-arteritic CRO with cerebroretinal aspiring, depending as per the FFA finding. Transient non-arteritic CRO and arteritic CRO. These are the classification commonly employed, but we usually non-arteritic and arteritic CRO, we usually adopt this etiology, this classification. So far as non-arteritic CRO is concerned, you can see here this is cherry spots. This is a fundus picture. This is cherry spots is the hallmark of this disease, and pale retina. And normal, if you go for the angio, you can see the normal perfusion of the optic nerve head. You can see there is I already told that ciliary retinal artery occlusion may be there in present, so it may be spurred, and we can have a pale retina all over, and again a strip of viable retina, where the patient can be very happy. Patient can see better even despite that arterial occlusion. So this is another variety, transient non-arteritic CRO. Here you can see cherry spot with few retinal hemorrhages, a small patent ciliary retinal artery, and normal-looking peripheral retina. This is angiographic picture. You can see the increasement of the foveal zone and non-filling of the artery. So far as arteritic CRO is concerned, it is very important difference between these two, because arteritic CRO is really a systemic emergency too, and you can see a delayed arterial filling with choroidal ischemia. That differentiate from the non-arteritic CRAO. So far as symptom is concerned, sudden monocular paleness, severe vision loss occurring over the second, pre-monitory emergencies figures may be there. Rarely purple hue of blurring due to retinal ischemia can be seen, and you can have hallucination in cases of severe vision loss associated with CRAO. Shines, you can have vision, there is sudden drop in vision, and you can have very severe visual loss. Usually up to count finger or even worse. You can have a PL negative patient if there is a ophthalmic artery blockage in those cases. So main stage is sudden painless diminution of vision with the which version suddenly. There is important point to know, the better visual acuity is in patient with CRO secondary to giant cell arteritis has been seen. The presence of an embolus is usually associated with poor vision on those cases. Eye with counting fingers or worse visual pregnancy presenting within 7 days of onset and had a best potential for improved vision acuity. A spontaneous visual acuity improvement is seen in up to 25% of cases with non-arteritic CRO. Less than 10% report a meaningful recovery. So, what are the factors determining visual outcome in those patients? The duration of the acute retinal ischemia is important. So if a patient present within the 90 minutes, 97 minutes of the occlusion, you can have no detectable damage in the circulation. If circulation restored, patient may recover vision completely. But if it presents late, almost 240 minutes of CR attack, it causes irreversible retinal damage. So but the irony is that most of the patients comes after many hours of the attack. So very difficult to restore the vision in those cases. And another determining factor is, what are the types of CRO? Causes and site of obstruction is also play the very important role. Residual retinal circulation, how much is left in the retina, is also important to factor determining of visual outcome. And the presence of area of supply by ciliary retinal artery is because it usually supplies the macular area. So finding is so far as finding in the detailed segment, you can have apparent papillary defect and intraocular patient may be normal or high. You may see rare VSCs iritis, so in some few percentage of cases, like 16.8% of cases, it is basically secondary to ocular ischemic syndrome, that is carotid artery obstruction. That is it occurs in 4 to 5 weeks after the onset, and or chronic CRO patient, CRO patients. This is the fundus examination. You can see here cataract tracking, cherry red spots and all. These are the chronic cases having disc collateral and non-perfusion optic nerve ischemia and NVD. You can see FFA is important to do in those cases to distinguish between the non-arteritic and arteritic CRO. In arteritic CRO, you can have a complete ischemia of the choroidal, so that way you can differentiate and save the patient life. So far as visual field is concerned, ciliary scotoma is most common defect observed in ARG. Severe attenuation of B wave then A wave as inner retinal layers are more affected, can be seen on OCT. You can see hyperreflectivity with thickening of the inferior retina. So it is important to investigate those patients. You have to have an area of investigation like CSR, reactive protein, lipid profile. In case of you are suspecting temporal artery arteritis, then go for the temporal artery biopsy, color Doppler, CT, MRI. So you have to have ruled all the systemic causes which can lead to hyperviscosity or thromboembolic phenomena, and your investigation is directed towards that. Treatment is very important, and idea of the treatment to dislodge the emboli to the lesser importance branches. So the major retina can be perfused. So once you present in time, you start digital massage to dislodge the plaque to the another branches, and you do AC anterior chamber parasensitive to lower the intraocular pressure, so that the normal ocular normal pulsation of the cardiac dislodge the plaque into the another site. IPS development in hope to okay, just 30 seconds. retrovasodilators, fibrinolytic agents, YAG laser embolysis can be done, or even surgical embolysis can be done later on, and it gives some vision, restore the vision in some patients. And to prevent retinal ischemia, we have to have a start carbogen inhalation. This is a mixture of 95% oxygen with 5% carbon dioxide, hyperbaric oxygen. Emergent transparanabrophyrectomy with perfluorocarbon liquid is important and has been done. Corticosteroid, as you know, arthritic arrow, anticoagulants, like if you are suspecting another cardiac causes. So this is the treatment and protocol, and you can basic idea to lower the intraocular pressure and dislodge the thrombus from that area. Thanks for your patience hearing.
Thank you, sir. Thank you so much for the elaborate presentation. Can I have my presentation, please? Yeah. Chemical injuries are true ocular emergencies, and it is the first treatment that we give to these patients. Which actually determines how the eye is going to behave in the future. It represents nearly 15% of all the trauma, and the worst thing, they affect young individuals. As many of these cases, they can go for medical legal issues, so it's very important to be spot on as an ophthalmologist when it comes to documentation. Alkali injuries are twice as common as acid injuries, and they are more devastating. There are multiple etiological agents, but if we talk about some common one, the most common alkali injury is lime or tuna. The most serious alkali injury is lye, which is found in drainage cleaners. Then most common acid injury is H2SO4 in bleaches and car batteries. Most serious acid injury is hydrofluoric acid used in glass polishing. One of the published report from RP Center in pediatric age group, when it comes to chemical injury, it is tuna injury, which is the most common, followed by toilet cleaner. As I said, alkali injuries are more severe, more devastating, more destructing, and there is a reason behind it. The increase in pH causes the saponification of the membrane lipid. This leads to greater penetration into the ocular tissue. And if at all it reaches the ciliary body is actually the source of ascorbic acid, which is essential for collagen formation, which is again essential for the reparative process. So if ciliary body is affected, obviously the reparative process is going to get affected. On the other hand, acid, when they come in contact with some of the proteinaceous agent, they form a coagulum, which actually restricts the further penetration into the ocular tissue. In addition, they cause shortening and shrinkage of the collagen fibers, which can lead to rapid increase in intraocular pressure. In cases of alkali, the rise in intraocular pressure is because of destruction of the angle structure. There are multiple systems of classifying these chemical injuries. The question arises, why do we need to classify? The classification system is based on how much of tissue damage is there over the ocular surface. So if we know the amount of damage, we will be more prepared to talk to the patient about the prognosis or what steps we need to take in the future. The first important classification was by Roper Hall. They considered limbal ischemia and corneal involvement. In any of the chemical injury classification, it is the limbal ischemia which has got the highest importance. So based on this, they divided this chemical injury grade 1 to grade 4. Grade 4 having the poor prognosis where half of the limbal ischemia is there. But this classification was given at a time when there was no facility of limbal stem cell transplantation. Now we know that with limbal stem cells transplantation, even with these so-called grade 4 injury can have good prognosis. And that was precisely the reason for having a revised classification, and which was given by Dua et al. It is still the most widely accepted classification of chemical injury. Here, they considered limbal ischemia along with conjunctival involvement because these are the two sites from where the reepithelialization process occurs. And what they did, they took grade 4 Roper Hall classification and divided that grade 4 into 4, 5 and 6. So if you pay attention to this grade 4 here there is 50% of limbus damage and 50% of conjunctival damage. And as per Dua's classification, very poor is only when there is 100% of limbal involvement and 100% of conjunctival involvement. So now there is another classification which has been published in the recent IJO. It was given by SN group of people. This classification is known as EPICS classification. E stands here for epithelium, P stands for pressure, I stands for ischemia, and X stands for exposure. They have this belief that it's not just limbus and the cornea or the conjunctiva, because there are so many other factors which are also here into action. So we need to have a combined classification system. So that was the idea of having EPICS classification. But here also the grading is exactly like Dua's classification. As you can see, this has been taken directly from Dua's publication. But in addition to that, they have considered bulbar conjunctiva separately, tarsal conjunctiva separately, and corneal epithelium separately. So epithelium has got all this component in addition to this limbus. Pressure, whether it is controlled or not. Ischemia, how much of scleral ischemia is there, and how much of globe which is exposed. And based on all this, the final annotation is given like this: which eye is there, what is the grade of injury. This will be as per the limbal involvement. Pressure, ischemia, exposure, similarly limbal epithelium, conjunctival epithelium, corneal, and the tarsal. This is actually an online grading, chemical injury grading system. The URL is not there in the public domain, but I believe this is going to be available to all of us in the next few months. And based on this, they have given an algorithm also for the management, which we will discuss in the next few slides. So when it comes to managing this chemical injury, the idea here is to restore the epithelium. We want to control the inflammatory process because that is very damaging, at least in the initial stage. Then we want to support the reparative process, and we want to prevent complication. And how do we do this? We treat the patient in different phases. But whatever we seen on the right side, 7 days, 3 weeks, these are the classical way of teaching it. The days can differ depending on our way of managing it. But as I said, this is an emergency situation, and the emergency management needs to be completely clear to us. The first treatment or the first idea here is to remove the offending substance and restore the physiological pH with the first fluid which is available to us. And in one of the published report, they have reported that in non-hospital setup, it is the tap water which is the most common solution which is used. In hospital setup, it is the ringer lactate which is most commonly used. But the choice of solution basically depends on osmolarity. We do not want to irrigate with a solution which is hyposmolar, because otherwise the solution will have a tendency to enter into eye. This will further increase the tissue edema. So we want a solution which is kind of hyperosmolar. So if I have to choose between normal saline, RL and BSS, I would go for BSS. But that is a little costlier than the RL solution which is available to all of us. But if we talk about the ideal solution, we need to go for diphoterin, quite hyperosmolar. In addition, it can neutralize both acid as well as alkaline without causing an exothermic reaction, without creating any heat over the ocular surface. That is important. We need to take help of eyelid speculum as and when required, Morgan lenses, nasal cannula, etc. And then the question arises how long we should irrigate. The ideal is again using a litmus paper, but that is not commonly we have in our hands in our routine practice. So minimum 30 minutes or minimum 3 liters of irrigating fluid should be used. Once we have done the irrigation, re-examine the patient. Particularly in Lyme injury, we will very frequently see it there, like those Lyme particles embedded deeper in the upper fornix, and they keep on eroding the ocular surface. So it's very examined to, do the double eversion if required, but check the fornices. And then we need to take a proper detailed history, document everything again, recheck, and then grade the chemical injury. The early phase treatment involves use of topical antibiotics to prevent secondary infection, topical cycloplegics to relieve pain, topical corticosteroid, the frequency of which will depend on level of inflammation. If I have a very severe injury, chemical injury, then I would go for prednisolone acetate in hourly dosing if required. Then topical or oral anti-glaucoma medication, my preference is oral. The reason being I am already using so many topical medications. Topical sodium citrate, the only available preparation in market is orocitrate by Orolab. They decrease inflammation by inhibiting the PMN degranulation. Topical tear substitute, tetracycline 1% or oral doxycycline, as they inhibit the collagenolisis. My preference is oral doxy. Then tablet vitamin C, 500 mg QID, BCL as and when required. Others are just theoretical. Then comes the surgical management in early acute phase. Traditionally, we have been doing amniotic membrane graft and tenons advancement. We want to put amniotic, we want to put a biological cover over it. We want to use the trophic factors which is provided by that amniotic membrane. We want to bring tenons forward because we want to bring vascularity in the area of damage so that the healing would be a little enhanced. So for example, in this case, this particular portion was, completely ischemic. So we removed this scar tissue and we cleaned the surface, brought the tenons forward. We put amniotic and BCL. But recently, not very recently, in the last 4-5 years, SN Group again they have come up with this idea that we can do allogenic simple limbal epithelial transplantation in the early acute phase itself. And why they recommend it? They have this belief, or the idea here is, when there is grade 4 or injury beyond that, when we do not have that limbal stem cell reservoir over the ocular surface, then just by putting an amniotic membrane graft or just by bringing the tenons forward towards the limbus, how this is going to help. So what they did, they took grade 4 or worse injuries, fresh injury less than 1 month old, they did the tenons management, they put an amniotic membrane graft, and they took these stem cells from donated fresh cornea less than 48 hours old, and this was the clinical picture they have published. And for visual rehabilitation, again, the autologous slit was performed. Then we need to keep revising our classification system if required. We need to do a close follow-up, whether it is completely healed or whether the defect is smaller than how it used to be. There is absolutely no sign of healing, or whether it is worsening. So we need to do, according to that, the further management also. We need to taper the steroid, and if we haven't done the surgery as yet, we need to do the surgery. If required, if there is a sign of ischemia and other stuff, then we need to go for repeat AMG also at this stage. So as I said earlier, depending on the EPICS classification by SN, there is this new algorithm also, which is about the management of acute ocular chemical injury, published in the Journal of Ocular Surface. For any case of ocular injury, chemical injury, we need to go for irrigation and then classify these injuries as per the given classification system. If there is an ocular surface inflammation, give topical steroid. If there is a low intraocular pressure, because low intraocular pressure also delays healing, the reepithelialization process, so give systemic corticosteroid. If the intraocular pressure is high, give anti-glaucoma medication. If the ischemia is localized less than 3 o'clock hour, we can observe. But if it is persistent beyond 7 to 10 days, or if it is worsening, do a tenonplasty. If there is a generalized ischemia, do the tenonplasty right at the beginning. Look for the exposure. If the person cannot close his or her eyes, we need to take care of that. So wherever needed, go for partial or total tarsorrhaphy. The idea here is to save the eye in cases of total tarsorrhaphy. If there is an epithelial defect and it is just a small corneal epithelial defect, putting a BCL will be sufficient. But if corneal epithelial defect is associated with more than 50% of the bulbar conjunctival defect, less than 50% of bulbar conjunctiva plus cornea, do AMG. But if more than 50% of bulbar conjunctiva plus cornea is gone, that means the limbal stem cells are going to be deficit. So in those cases, we need to go for the allo slit. If along with this, tarsal conjunctiva is also involved, then we may need to go for the oral mucosa graft. That is how the algorithm is. In addition, if there is a sign of scleral melt and other complications, we need to go for all the supportive treatment, do AMG, use tissue adhesive, do lamellar keratoplasty or PK as and when it is required. The final phase involves, we need to continue the supportive treatment depending on the health of ocular surface. We need to prepare the surface. We need to take care of inflammation. We need to take care of the lid. Because many a times a simple scar over the lid, for example, this was a molten metal injury, and there was this scar at the tarsal conjunctiva, which was just not allowing this epithelium to heal. We simply removed it, put an amniotic membrane, not even a mucous membrane graft, and this healed well. So we need to prepare the surface for the future intervention or the future visual rehabilitation. That is the entire idea here. And that depends on what kind of surface we are dealing with. If we have a wet surface, unilateral LSCD, go for autologous slit. If we have a bilateral or one-eyed patient, we may need to go for allogenic slit, but that requires systemic immunosuppression for a long time. Or we can go for Boston K-Pro type 1. In cases of dry surface, we have very few options. It's all about K-Pro, whether it is MooCup or type 2 Boston K-Pro or LVP or Lux, which are kind of, almost similar pattern. So that is how it works. So if you ask him what is my take-home message from this entire thing, then it is the emergency management or the first treatment that we are giving to the patient is one of the important decision makers. In severe chemical injury, we should not keep the surgery reserved for later stages. As and when it is required, do it at that point of time. With this, I would like to say thank you. Thank you for being a part of this IC. Thank you all the speakers. Thank you so much. If there is a question.
This talk is going to be totally different from what you heard. I don't know why they put it in this session. I hope to make it as interesting as possible. It is on acute comitant esotropia precipitated by excess near work during the COVID-19 induced home confinement. Yeah, so no financial interest. So for most of you who don't know what is AACE, this is acute acquired comitant esotropia. It is nothing but an acquired non-accommodative esodiviation which happens suddenly of acute onset, often associated with diplopia, but comitant, which means it is same in all gaze directions. So you have suddenly someone who presents with a sudden inward squint, which is not there earlier. So it is seen in previously straight-eyed patients, usually seen in children, but can occur in older people also, older children, adults, and even in the elderly. So AACE has 5 different subtypes. Type 1 is a SWAN type, which occurs after a period of interrupted binocularity, like a patch. You put the patient on patch for some, trivial trauma or something. Then there is a Burrian-Francisci type, which is associated with minimal hypermetropia and diplopia, often precipitated by some physical or psychological stress. So the child may be having an underlying esophoria, and suddenly due to stress, it manifests into a tropia. Then you have the Belchowski's type, which is seen typically in myopes with convergent spasm and divergence paralysis. So myopes, do you know that they like to look at near more often? They don't like to look far. So they don't use the divergence. So there is divergence paralysis, and excess use of convergence leads to convergent spasm. Then the lesser known ones would be the refractive accommodative type, which is characterized by high hypermetropia, which is adequately controlled by a refractive correction alone. This is the typical hypermetropic accommodative esotropia, which is typically missed and presents to you. Then there is a more dangerous one of an intracranial pathology, which is a lesser common entity, most commonly a posterior fossa tumor like a diffuse pontine glioma, which can present in the form of a sudden onset of esotropia in a child. So these are the common types. So this study was done in the COVID pandemic. With the COVID pandemic, we had the new norm of work, study, and play from home, and everything changed for us. Study, work, everything changed. So with the onset of COVID-19 crisis, we became increasingly digital. A total of 320 million learners in India transitioned into e-learning. And we had a massive rise in people working from home with increasing dependence on gadgets for studies, work, and leisure. So we saw a substantial increase in number of children and young adults with complaints of recent onset of inward squinting and double vision coming to a hospital, which prompted us to do this study to examine the causes of acute acquired comitant esotropia or AACE in young children and adults in the setting of COVID-19 induced home confinement. So materials and methods, it was a retrospective clinical study of all those who had acute acquired comitant non-accommodative esodiviation who came to the pediatric ophthalmology department of our hospital from August 2020 to January 2021 during the pandemic season. So materials and methods, these were the diagnostic criteria, all those with acute onset of esodiviation within hours, days, or week, age of onset after 1 year of age, with photographic evidence of previously aligned eyes, a comitant esodiviation with normal ocular movements, no restriction or limitation of ocular movements. So parameters evaluated were these: demographic features like age, sex, occupation, and class of study, a careful history regarding the duration of complaints, any precipitating events, previous and current use of glasses, then the details of near work including the nature, duration, and medium of work, then the complete ocular examination including visual acuity, binocular status both for distance and near, squint evaluation including the amount and type of esodiviation, an atropine refraction was done in all, and a dilated fundus examination was also done. So ancillary investigations included a complete orthoptic evaluation, including parameters of accommodation and convergence and vergences. And in all patients, we did a magnetic resonance imaging of the brain and orbits. And those which we felt needed a neurological assessment, we sent them to the neurologist. So these results, we had total 15 cases in our study, 11 males and 4 females. Most of them came to us with complaints of double vision and squint, that is 73.3%, and some with diplopia alone and squint alone. So the mean duration was about 2.98 months, mean duration of presentation, and it ranged from 15 days to 6 months. So age ranged from 5 to 24 years, with majority above the age of 10 years. And the mean age was 16 point. So majority in a group with students, that is about 73.3% with students, so young population, and the rest were employed. There was no precipitating event in most of the patients except excess near work, except one patient who gave a history of fever prior to the onset of ESO deviation. So when we looked at the hours of near work and the medium of near work, we found that the duration of near work ranged from 3 to 12 hours a day for most of the patients, and the mean duration was about 8.6 hours per day, with majority having more than 8 hours of near activity. And the near activity was related to online classes in most of them, that is in 53.3%, official work in 20%, playing games on gadgets in 20%, and religious text reading in 6.7%. And if you look at the medium of the work, smartphone was the most common medium of work in most of the patients, that is in 86.3%. So when we looked at the refractive status, majority of the patients in our study had low hypermetropia, that is about 60%, that is spherical equivalent less than 2 diopters. Few had moderate hypermetropia between 2 to 2.5, and the rest had myopia, that is about 33.3%. Of the myopes, 7 patients had glasses, of which 5 were myopes. And interestingly, 3 out of the 5 myopes admitted to taking off the glasses and doing near work during the pandemic period, because they felt they didn't need to look at far and they could see well for near. They started taking off the glasses and doing the near work. So average esotropia in our study for distance was about 22.73 prism diopters, and for near it was 18.73 diopters. So the range was roughly from 10 to 45 prisms. So if you look at, most of them had double vision. Few were able to have, one patient had fusion and the rest had suppression on Würzburg dot tests. The mean stereopsis was still good, 116.67 in majority. So orthoptic evaluation was essentially not very abnormal, except for 40% of patients showing poor divergence for distance, that is poor negative fusional divergences. Few had high positive relative accommodation and high AC by ratio, but otherwise it was almost normal. So what did we do with these patients? So we decided that all those with pre-existing or newly detected refractive errors were given glasses for constant use. All those with or at the risk of amblyopia were started amblyopia therapy in the form of occlusion therapy. All were advised to restrict and reduce their near activity, especially on mobiles. Those with divergence insufficiency esotropia, in which we found that the divergence was poor, were given divergence exercises in the form of eccentric circles or prisms. In 5 patients, the reduction of near work with divergence exercises was helpful, and it helped them to control the ESO deviation and double vision. But few patients required prismatic therapy also, like 2 patients were given ground prisms, both with myopia and divergence insufficiency. These were smaller prisms, so we could grind them in the glasses. Now, those with basic type of acquired comitant ESO deviation were advised squint surgery because they had very large angles and they couldn't fuse at any way. So these 4 patients, 3 with low hypermetropia and basic type and 1 with Barian-Francisci type of ASE, underwent squint surgery and regained binocularity. So these are some of the pictures of these patients who underwent surgery. You can see in the first picture, most of them are straight. In the second picture, they started having the ESO deviation when they came to me. And in the last picture, they regained their alignment and binocularity. So this is another patient, an IT professional who developed ESO deviation during the pandemic, had diplopia, underwent surgery and had good improvement. So we found 4 categories of patients with this acute ESO deviation in our study. First was myopes. Now these myopes had divergence insufficiency. Okay, so the distance esotropia was much more than the near esotropia, occasionally almost equal. So they would fit into the Belchevsky's type of ESO deviation. Then we had the low hypermetropes, less than 2 diopters of spherical equivalent hypermetropia with basic type of ESO deviation, same angles for distance and near. Then we had an occasional low hypermetrope with divergence insufficiency esotrope. and the moderate hypermetrope, in which the ESO deviation was precipitated by stress, which you could classify as the Berean-Francisci type. But the only common factor in majority was excessive near work. And so we had similar literature reports during the pandemic by Aldo Vage et al., who reported 4 cases of acute esotropia during the COVID pandemic. We had earlier reported a series of esotropia in younger patients who did very well with surgery. Then Lee et al. Reported esotropia with in patients who used smartphones for longer duration, and Yanwu et al. Also. So what is the etiology? So I'd like to just postulate that the increasing use of smartphones and tablets in modern life, with more and more near work coming into play, everything done at near, both at work and play. So there is an excessive use of near work, and naturally stronger convergence in the younger population leads to an imbalance between accommodation and convergence, leads to dynamic activation of the medial rectus muscle and development of a manifest esotropia. And this is more in hypermetropes, naturally because of the greater accommodative demand, and this was also seen in our study. But do you know that even myopes can develop ESO deviation? So this is a postulate which is already postulated by Belchevsky, which we thought worked in our case also. If you have an uncorrected myopia and you hold books or text excessively close to eyes without using your glasses, there is again an increased tone of medial rectus and lack of distant stimuli leading to divergence paralysis, again leading to an acute acquired comitant ESO deviation and manifest esotropia. So 33% have myopes in a study who developed an ESO deviation. So to conclude, we have to really look at the use of increasing digital time in our population. Luckily now the pandemic is gone, but when you have an online class in excess, you have to think of this as an important side effect, acute acquired comitant esotropia, and we have to regulate the hours of online learning and even online play, whatever it is. So that is, the habit of long-time sustained near work, especially on smartphones, has a risk of inducement of AAC, and we should be able to remember this and take specific recommendations to mitigate this undesirable effect. Thank you.